Is is there any question from the previous lectures that we had? Any question? Seems some people haven't joined. Uh, so Lawrence, your other class rep hasn't joined. Have you guys found out why she hasn't joined?
I haven't found out yet.
Those who are in the hostel with her. Why hasn't she joined? Please, you have to prompt her to join. And the others that are in the hostel, but they are not here. Okay. All right. Actually, we cannot wait for them because it's almost 5:30. We have to start. I think it's 5:30 already. Yes. So we have to start. All right. So if there are no questions from the previous lectures, we will start. But a quick recap from what we did last week. Last week we started with the prelims. Yes, the prelims with regards to the abdominal sonography, but we were more on the liver. Yes. So I told you that we have some tubular structures in the liver, and also the portal veins, hepatic veins. Then we also have the bile ducts. You understand, passing through the liver, the intrahepatic ducts, and I told you that on ultrasound, the difference between the portal veins and the hepatic veins are that the portal veins are large in size. And then we also said that there is deposit of collagen at the walls. So portal veins have thick walls. Do you understand? And which we told you that for hepatic veins, they are not that big as compared to the portal veins, and they don't have the thick wall. Portal veins have white kind of wall. That's echogenic, hyperechogenic walls, but hepatic veins do not. You understand? Then we said that when you're comparing them to the hepatic arteries, the hepatic artery is not also that big. The artery also has thick wall because arteries have thick wall already, but they are not big. And arteries also pulsate because the heart is beating under high pressure. So the artery will also synchronize with the heartbeat. Do you understand? So you see the artery pulsating. It's not that big as compared to the portal vein. And when you put your Doppler, you will see them clearly. You see that this is red, this is showing red, this is blue. So if it is showing red, you know definitely this is what the hepatic artery. If it's showing blue, then you check the size and the walls. If it's showing blue and the walls are white and it is large, it is portal vein. Do you understand? If it is small and the walls are not echogenic, it's not hyperechoic, then it is what? Hepatic vein. If it's not showing any flow at all, then it is what? Who can tell me? If the vessel is not showing any flow on Doppler at all, then what vessel is that?
Common duct.
Common duct. Okay. So those are the intrahepatic bile ducts. Yes, that's it. All right. So that's good. So we also said that we have two main loops of the liver, but there are other accessory loops. So the two main loops are the right and left. You understand? When you multiply the left loop by 6 times, you get the right loop. It means that the right loop is very large. Yes. We told you that the left loop is the part of the liver that extends to the epigastric region. When the liver enlarges, the left loop can even go to the left hypochondriac. Do you understand? Yeah. So that is it. And that's why we call it left loop. It moves towards the left part of the body. Do you understand? All right. Even though we talked about other stuff, so you can go back to the notes. Now we go to the liver ultrasonography. I think we even went okay, we got here rather, yeah. Liver ultrasonography, that's fine. Okay. Still, if there are no questions, I continue. So the probes that we use for scanning, general scanning, are the linear probe, curvilinear probe, and the phased array probe. And we have done physics, so you should know this. I mean, which one is the best? Please, what do you think? Among these probes, which one do you think is the best for abdominal sonography? The best, generally, for abdominal sonography?
The curvilinear probe.
The curvilinear probe. Good. The curvilinear probe. Yes. So the frequencies can start from as low as 1.0. You understand? I've brought this one here because it's the average. It can come as low as 1.0 to 7.5 megahertz. Yes, 7.5 megahertz, not just 7. Yes, so the 2.5 can be lower than that, depending on the type of curvilinear probe that you bought. You understand? But the highest of curvilinear that you can get is about 7.5 megahertz. Do you understand? All right. So the average of all curvilinear is what? 3.5. That's the average. So most machines that use curvilinear, once you switch on the machine and the curvilinear probe is connected and you choose that curvilinear probe, you see that the frequency is set to the default, which is 3.5 megahertz. So you can decide to change it. All right. Linear arrays can be used, but linear array is only used when you are expecting something very tiny in the abdomen, but you are not seeing something like the appendix, something like you are suspecting something we call the Crohn's disease, those inflammatory bowel diseases. Those ones you have to utilize the linear probe. For linear probe, naturally will magnify the image. It will maximize your view. Yes, but you don't generally use linear probe for abdominal scan. Do you understand? Phased array probe, as you know, who remembers the use? Which part of the body do we use phased array probe?
I said the heart.
Exactly. So the chest, you understand, which the heart is the prominent organ there. Not only the heart do, but the lungs are also there. You understand? The lungs are there. Okay. All right. Now the field of view of curvilinear, you see the field of view, it's wide. Yes. We know that it has low frequency, wide footprint. You know the footprint because you have done physics. Wide footprint. It widens like that. Yes. Let me see. Somebody has written something. Please, can we use linear probe for mesenteric lymph nodes? Definitely. Yes, you can. You can. Because those mesenteric lymph nodes, if you don't use linear probe, which will magnify it, sometimes it's difficult to see them. If you use a curvilinear, sometimes you find it difficult. Unless you press and press and also magnify the image, like zoom the image, make it big. Yes. So linear probe is good. But linear probe, don't forget, since it has high frequencies, even though the penetration is strong, but wavelength, you understand, the wavelength will not go that deep. And so if you don't press very well, you are not going to get it to go deeper. Do you understand? And so you have to press so that you displace the bowel gases, so that the beam can pass through all the abdominal wall to go into the mesentery to find those lymph nodes. You understand? All right. Okay, so that is it. So low frequencies, wide footprint, deep structures. It's for deeper structures. You understand? Which you know all these already. So the normal lever is what we are seeing on the screen. So we'll talk about the size, the shape, echogenicity, and the echotexture. Please, what structure is this? Where my cursor is? What structure is this? Who knows?
The diaphragm.
The diaphragm. So the diaphragm, you understand? That's the diaphragm. This is the lever. This whole thing is the lever. This whole thing you are seeing here is the lever. This structure here could be the gallbladder, but the focus wasn't on the gallbladder. You understand? These tubular, these dark structures are the portal. They could be portal or hepatic veins, but the focus wasn't on them. We have done them already. Those tubular structures. Okay. Now, measurement. Ultrasound estimation of size can be made by measuring the sagittal length of the lever. Have we done this already? It seems I've taught some people recently, or it's not you. Okay, all right, let's continue. Ultrasound estimation of size can be made by measuring the sagittal length of the lever in the mid-clavicular long axis. You already know the mid-clavicular line, right? Because we treated the gynecology one and the normal anatomy and physiology. Yes, so mid-clavicular line, MCL. Do you understand? You know it already, right? So the clavicle here, there is a bone here from the shoulder here to the front of the neck here. You understand? Like from this place to this place, there is a bone. You can touch it right now. There is a bone. And there is another bone here. So when you stand in the middle of that bone and you draw a straight line, it passes through the breast, like the nipple of the breast. That's where it passes. And then it goes down straight. That's a mid-clavicular because that bone is called clavicle. So if you stand in the middle, it is mid-clavicle, mid-clavicular. So you draw a line straight. So at the right side, that's where the lever is. So we want the right mid-clavicular line. So that's where you actually take the measurement from. The normal length is less than or equal to 14 cm. That's actually the normal length of the lever, but don't forget, we have some variations. So let me hit on that. Because people will think that then when I measure the lever and I'm getting 14.5, it is abnormal. No, it doesn't mean that. So hepatomegaly is enlargement of the liver. Hepatomegaly is something common that you see it all the time. Hepatomegaly is not a disease, please. It's not a disease, it's a sign. It's a sonographic sign that there is liver problem or there is a problem going on in the body. So hepatomegaly is just a sign, it's enlargement of the liver. It's like jaundice. When you see someone's eyes, the white of the eye is yellowish. The palms and the soles of the feet are yellow. It doesn't mean the jaundice doesn't mean it's a disease. Jaundice is a sign, meaning something is wrong with the liver. Do you understand? Something is wrong with the liver. That's jaundice. It's a sign, not a disease. So hepatomegaly is enlargement of the liver, which is a sign, not a disease. The disease is there. Something is causing that. So that is what you have to find out. If you see hepatomegaly, you have to find out what is causing it. There are tens of conditions that can cause hepatomegaly. Even simple, even the malaria that we have, malaria. It may not be simple, though. The complicated malaria can cause hepatomegaly. So hepatomegaly is considered when the length of the liver is greater than what? 15.5. So before you see that the liver is enlarged and it is abnormal, the length should measure more than 15.5. Do you understand? Should measure more than what? 15.5 centimeters in the mid-clavicular line. I've already mentioned the mid-clavicular line. You don't measure the liver in the mid-axillary line. No. It is in the mid-clavicular line. And we will see how to go about that. So measurement between 14 centimeters to 15.5 cm are in the gray zone. You understand? So I said it earlier here that the normal dimension should be less than 14. However, from that 14 to the upper limit, which is 15.5, is in a gray zone. That depends on the body habitus. You understand? When we say gray zone is like the borderline. Yes, it's the borderline from this 14 to 15.5. When you are there, your liver size is there, it's not really a problem. But we look at your body habitus. Yes. If you are cute, and then your liver is measuring 15.5, definitely your liver is enlarged. Because once you are not fat, you are not too tall, your liver should be 14 or less. Do you understand? But if you are tall, a tall person, and then you are also a bit robust, fleshy, we expect that mostly the height is very important when it comes to liver size. So if you are tall, especially the men, we expect that your liver will go beyond 14. But no matter how tall you are, it shouldn't go beyond 15.5. Once it goes beyond 15.5, it is a problem, meaning it is what? Hepatomegaly. Do you understand? Even though there are some researches that people are doing now, that some of them can say that liver can get to up to 16, because some people are very, very tall nowadays because of the growth hormone that they inject when they are young. So that one, yes, but in Africa, no, it's not part of us. If you go to Europe, those playing basketballs and those people, yes, they are very tall, 7 feet and cool. Those people, if they get 16 cm, it's not hepatomegaly. Do you understand? In Africa, here, especially Ghana, 15.5 is the end. I mean, that's the upper limit that you should go, no matter how tall you are. Do you understand? So we are saying that the body habitus is very important. The body habitus, you consider that. Male liver is generally considered larger than a female's liver. Let's understand that. A liver measuring 15 cm in length in a tall male is what? A normal size. But in a short female, this length may represent hepatomegaly. Because I've already told you that the normal level should be less than 14. However, depending on your body habitus, we can say that it is normal. When you get even 15.3, 15.5, it's normal. In females, generally, we don't expect their level to go beyond 14. In females, we don't expect their level to go beyond 14, with the exception of some tribes in the country that their females are very tall. Yes, for them, they compete with the men for liver size. So for them, if you measure their liver size and you are getting 15.3 or even 15.5, you cannot say it is enlarged unless it goes beyond that. Do you understand? So the bottom line is that for you not to be confused, I'm saying all this so that when you go for an interview and you are asked a question, you know how to answer the question. Because it's not like it is fixed. The liver size should be less than 14. It is fixed. It's not like that. That's why I've talked plenty on it. It's not fixed. It shouldn't go beyond 15.5. But most liver should be less than 14 cm. But depending on your body habitus, you can go beyond 14, like 14.5, 15 up to 15.5. Do you understand? Depending on your body size. But put it in your head that in clinical practice, when you are practicing, for you not to be confused, take note that no liver must exceed 15.5 in mid-clavicular line. 15.5 centimeters in mid-clavicular line in West Africa here. Yes, especially we are practicing in Ghana. We are not in Europe. So 15.5 or less should be the normal size liver. So just take it that way so that you are not going to make mistakes. You are not going to forget things. Yes, when you measure someone's liver and it's measuring 14.5, you can write it as normal. Yes, it doesn't change anything. Yeah, but the moment it exceeds 15.5, please, it is hepatomegaly. But remember, hepatomegaly is secondary to what? What is causing the hepatomegaly? There should be something, even though it's not all the time that ultrasound can pick that thing up. Because if it is malaria, ultrasound cannot pick it up. So you just have to write enlarged liver, or you can write hepatomegaly, then into bracket the measurement. So the doctor will correlate that your ultrasound findings to the lab test and know that, oh, okay, this person is having severe malaria. That is why there is what? Hepatosplenomegaly, because severe malaria will cause the spleen to also be enlarged. So we call it hepatosplenomegaly. The spleen is enlarged, the liver is enlarged. So that's it. But sometimes ultrasound can find out why the liver is enlarged, which you see it and you have to add it. If you see that the liver is appearing like liver cancer, definitely hepatomegaly secondary to hepatocellular carcinoma, because it is the cancer that is causing the enlargement. Do you understand? But you see, ultrasound, we don't use it to confirm cancer. You can use it, to just suggest it. The confirmation is what you have to go and do what? Histopathology. That is biopsy. You have to take some of the tissues from the organ and send it to the histopathologist. He is going to view them under the microscope and tell us that this is cancer. Ultrasound will see the features of the cancer, but ultrasound doesn't confirm. Do you understand? And we will talk about those things. Okay. All right. So have you seen how to measure the liver? This is the right kidney, isn't it? What is the name of this part of the kidney? We are not at the kidney yet, but what's the name of this part of the kidney? Who can tell me? No one. Really? Oh, the echogenic aspect of the kidney. I see. All right. Eric, can you come again? Okay, somebody.
Renal sinus.
Okay. Yes, I think Isa too has written it here. That's the sinus. All right. That's good. Yes, that's the echogenic part of it, of the kidneys. That's the sinus. But we are not there yet. Don't worry. When we get there, we will do the anatomy and the physiology of it before we move to the ultrasound. Okay. So this is how the liver is measured. You start from the diaphragm and you measure, you slant it. Have you seen how it is slanted? You slant it like that. Uh, you have captured the liver this way, and you are going to stand here, and you measure it this way. No, how can you measure a liver like this? You have cut it into two. We don't do that. This is like transverse cut. No, but you don't cut the liver like that. You get abnormal measurement. You have to make sure that the tip of the measurement is on the diaphragm. This is the diaphragm. This is the diaphragm. You have to make sure it's on the diaphragm. Then you drag it to the other end. Have you seen that the left loop has gone inside? So the left loop has gone inside, like that. So you have to measure. You can think of where it ends. Yes, and you extend it above this line small. Sometimes you get the lever fully, depending on how you stand. You can get it in the mid-clavicular line. You can get it in a way that you can measure from one end to the other end. On ultrasound, we don't measure the lever like you are getting the full level. No, you don't get the full level. It's not like that. That's why you have to get it in the mid clavicular line. When you get it in the mid clavicular line, everybody knows that it's not the full level. But that is how we measure it. That's how we measure it. If you stand at the epigastric area and you slant your probe in a way, you can get the full lever, and lever is very big. The full lever, some people, especially the herbal clinics, can measure the lever from the diaphragm to the left loop and can get like 20 centimeters, 20 centimeters, and will tell you that your liver is enlarged. We don't measure liver like that. Yes, those who are working, you know what I'm talking about. The liver should be seen nicely like that. You don't position your probe in anywhere you want and get the liver huge, like very big, and you start from the diaphragm and you measure to the left loop at the other end. No, we don't measure the liver like that. So you capture the liver well. Mostly we need to see the right kidney also. You understand? So that we know that it is the liver that you are measuring, because the liver is sitting on the right kidney. So you capture in the mid clavicular line. You stand there. You get the liver nicely, and then you measure like that. You slant it and measure it like that. Okay, let's see if I have other images. So sometimes you get the liver like this. Have you seen that? Here I'm having the left loop here nicely, but have you seen the right loop? All these places cut off because you cannot get the full liver. It's like it is wrong to get the full liver on imaging unless you are sweeping around. When you are sweeping, like you are searching, you are not measuring, you are just searching around. That one you can position your probe in such a way that you get the full liver. It's not for measurement, please. If you are going to get all the right, the right loop. Have you seen that the right loop is cut off over here? Because the right loop goes, the diaphragm goes higher. The right loop The right loop can go like this. Eh. Do you understand? So that place is cut off. If you want to measure, yes, that's how it should be. It should be. You don't have to get the full lever on the screen. You get wrong measurement. Because where you have to position your probe, you cannot get the full lever when you want to measure. So those people that force themselves and get the full lever, I'm telling you that they are those that cheat patient. Yes, they cheat the patient. They will intentionally measure the full lever and tell you that your lever is enlarged. Meanwhile, it is not. So this one, if you want to measure, can you tell me if I'm standing here and I measure up to this place? I'm standing here and I measure up to this place. Or I'm standing here and I measure up to this place. Or I stand here and I measure up to this place. This is A, this is B, this is C, this is D. Which one will you go for? I stand here and I measure up to this place. E. Which one is correct?
Say the E.
The E. Okay. Is there any other suggestion?
The E.
The E. Okay. All right. So yeah, that's fine. Yes. Many people measure it that way, the E. Even though some few people will measure the D. Do you understand? But the rest are not, they are wrong. Totally wrong. Yes, many people will use the E, which is the most used. But then the D, some people also use the D in some way. Yeah, which may not be too wrong because the difference between the E and the D is just it's not that significant though. But of course, it can add up to increase the measurement. Do you understand? So if you do it the E, then it's fine. So that you get the accurate measurement. Okay. So have you seen the right kidney there? That's it. So everybody will know that indeed this is a huge a huge organ. And once we are seeing the kidney there, we know that's the liver. If this mass over here was to be a bit small, we know that it's the spleen. So this kidney will be the left kidney. Do you understand? All right. So let me move back. So the normal liver is a moderately echogenic parenchymal organ. When we say parenchyma is just the tissues, parenchyma. So if I'm seeing this liver, all this is liver parenchyma. You understand? Liver parenchyma. That's the liver tissues. Somebody has written something. Let me check. Please, is it compulsory to always capture the liver with the kidney before you measure the liver? That's the best. Especially if you're writing exams and you capture the liver and the kidney is nowhere to be found. Please, no. That one, they wouldn't accept it. Because what if we are not seeing the kidney? If we are not seeing the kidney, how are we going to see the Morrison's pouch? Because we have to see the kidney so that we will know that the Morrison's pouch is what? Free. When we capture the liver, the kidney has to be seen. Yes, at least part of the kidney. If even not full kidney, part of the kidney has to be seen. That's it. It's the same way when you capture the spleen, part of the left kidney has to be seen. Yes. So even though we have individual differences, so don't forget anatomy, we have variations. Anatomy, we have variations. Yeah. Somebody will come with only one kidney. The other kidney is not there. And he hasn't undergone any operation or surgery before. One kidney. Only the left kidney, right kidney is not there. So you search and search and search, you will see it. At that instance, it is not compulsory for you to try and still get the kidney is not there. Do you understand? So we have some variations, but it's good that you capture the liver, letting the kidney show. Not like the kidney should be fully seen all the time, but at least part of it must be seen so that you can label this is the kidney, right kidney. Once you label the liver, you can just see the kidney, or you can just say kidney. It's not needed to say right kidney, because we know that the liver is on the right side. So once you label the liver, the kidney, just label it kidney. Or you can decide to also make a right kidney. It's all fine. All right. So as I said, the parenchyma is just the tissues of the organ. It has a fairly homogeneous ecotexture. The liver is fairly homogeneous. So if you see this liver, you can see how nice this liver is. Very nice, right? Okay. Which is interrupted by what? Tubular structures traversing through its substance. We have talked about the tubular structures, isn't it? We have talked about the tubular structures. Yes. I mentioned them before I started this presentation. The portal veins, hepatic veins, the bile ducts, and the rest. They are the tubular structures traversing through the liver. These represent blood vessels, usually hepatic, portal veins, which appear as anechoic tubes or circles, depending on how they are sliced on the given anatomic section of the liver. Please, if you see the portal vein like this in the liver, and you see it like this in the liver, there's the wall of it. Which one? This is A, this is B. Which one is transverse and which one is longitudinal? Portal vein being seen like what you are seeing on the screen. Which one is transverse? When you are standing on transverse, how are you going to see the portal, the veins, not just the portal vein, the tubular structures or the tubular structures? When you see it as A, is it in sagittal or transverse? When you see it as B, sagittal or transverse?
A is sag and B is trans.
Okay. So A is sagittal, because on sagittal, you see the full structure. So just think of the uterus. When you stand on longitudinal, you see the pear shape. But when you stand on transverse, it cuts the uterus and makes it like a circle. Do you understand? So you have to understand that. So it's not like if you see the liver and you see circular thing inside, then you are saying, oh, this is a cyst. This is a cyst. Please. Just tilt your probe. Stand sagittally. You will see that it is tubular structure, not a cyst. Take note of that. It's very important. All right. So the dome of the right loop is bordered by hyperechogenic curved structure called what? The diaphragm. We all know the diaphragm, right? Okay. So the renal medulla or the medulla, we are talking about echogenicities, the parenchymal organ echogenicities. So we are comparing the liver, the spleen, and the pancreas, and even the kidneys. So let's see something. The renal medulla, which is here, the medulla is this part. It's like this. So it passes here like that. So all the hypoechoic stuff over there, if there's we are not treating the kidney now, but the medulla is somewhere here. The medulla is somewhere here, and the cortex is the outer part of it, getting to the outer part of it. You understand? And the sinus is the central part of it, but the sinus contains what we call calyces, and the renal pelvis is also there. However, as I said, we are not in the we are not at the urology yet. So what I need you to understand is that when you compare the sinus here to the liver parenchyma, which one is echogenic? You can see that the sinus is what? Hyper echogenic than the liver parenchyma, isn't it? Yes. But the cortex, if you see the cortex or the medulla, it's either the same or the liver is hyper than the kidney's own. Do you understand? So that's how it is. You are just comparing the echogenicity here to this one. When it comes to the liver and the kidney, you are comparing the echogenicities. So if we compare the renal medulla and the cortex and the liver, we are saying that, please, what is this sign? This sign is what? This sign, it is what? This is which sign and this is which sign? Who can tell me? This one is which sign?
Greater than.
Less than.
Hey, some people are saying greater than.
Less
Some people are saying less than. So
it's less than.
it's
Yeah,
less
less
than.
than.
So
And
why
the
are
one,
you?
the other one is less than or greater than.
This is okay. That's good. You said less than or greater than. Are you sure?
Less than or
No,
equal to say.
Less than or equal
less
to.
than or equal to. And
Yes.
the other one is less than.
Okay. So this is less than. This is less than, and this is less than or equal to.
Equal to.
You understand? When it turns the other way around, facing backwards, that is what when we say greater than. You understand? But this is less than. Okay. So the renal medulla, the echogenicity is less than the cortex, meaning that if you start from the back, the liver echogenicity is greater than or equal to the cortex. Take note too, if you are starting from here and you are coming back, the liver echogenicity is greater than or equal to the cortex. But if you start from the cortex, then the cortex echogenicity is less than or equal to the liver. That is mathematics. This is simple. If we start from here, the renal medulla is less than or equal, the echogenicity is less than or equal to the cortex, meaning the renal medulla or the medulla, which some people may say, the echogenicity, it means that the cortex is a bit white than the renal medulla. Because once you go and start here and you are coming back, you have to use greater than, because even though this sign is less than, but this less than is going for the renal medulla. So renal medulla is less than the cortex. But if you start with the cortex, then the cortex is greater than the renal medulla. That's how it is. So renal medulla echogenicity is dark, a bit darker. It's dark. You can, if you compare it to the cortex is a bit white than the medulla. Then when you compare the cortex to the liver, you know that the cortex is also less than or equal to the liver. It's like it's either the same, the echogenicities are the same. That's why we are saying that less than or equal. Either they are the same or the cortex is a bit darker and the liver is a bit white. That's why I showed you something here that if you check the liver very well, it's a bit white than this place. The liver is a bit white than this place. You understand? That's what we are saying is equal to or less than. This cortex less than the liver, meaning the cortex is a bit darker, the liver is a bit white. Do you understand? This is English and also mathematics, so you have to understand. If you pick the liver and the spleen, let me show them to you. This is the liver. This is the liver. The L is the liver, the spleen. Please, what do you see? Compare the liver echogenicity and the splenic echogenicity. Which one is having higher echogenicity than the other? Which one is hyper?
So the spleen.
The spleen is hyper.
Hyper, yes. And so it means that spleen echogenicity is what? Greater than the liver. Do you understand? So let's go back. So you see the liver here in the spleen. So either the spleen, I told you that if you have less than here and you start from the back, you should talk about the greater than. Because if you are starting from the back, then you are turning it. But if you are starting from in front, then the liver echogenicity is less than the spleen. That's how to go about this statement. Liver echogenicity is less than the spleen because this is a less than sign. But if you come back and start from the spleen, then the splenic echogenicity is greater than the liver. That's it. That's it. If you come here, this is less than or equal to sign, right? So the liver echogenicity is less than or equal to the pancreas. That should tell you that the pancreas is what? Who can tell me? That should tell you the pancreas is what? The pancreas could be what?
The
Greater than or
pancreas is
greater than or equal
more
to the
hyper
liver.
than the
Yes, so greater than or equal to the liver. But most of the time, the pancreas is hyper than the liver. Yes. So if you see this sign over here and you start from the pancreas, then the pancreas is greater than or the echogenicity is more hyper than the liver. But it is greater than or equal to. So it could be equal depending on fat deposit on the pancreas. Because the pancreas, yes, fat can be deposited on it and it changes its echogenicity. So the liver echogenicity is less than or equal to the pancreas, meaning the pancreas is higher or equal to the liver. That's all. So let's see if I find it. Yes. Have you seen the pancreas? That's the pancreas over here. There's the pancreas, head, body, and tail. Yes. We have done it in the digestive system, the regular students. Yes. And we are still on the digestive system. We are not done yet, but we have done the pancreas. You saw the head, body, and tail. I told you that the head is divided into two parts. Who remembers? The pancreas. The head is divided into two parts. No one.
The neck.
the proper.
The head proper. Somebody said the neck. Fine. The neck, you are not wrong, but the neck, then on ultrasound, we actually don't add the neck. The neck is more or less part of the head on ultrasound, but in proper anatomy, the neck is there. Do you understand?
The uncinate.
The uncinate process. Good. Okay. So check the left loop of the liver. Have you seen the left loop of the liver? There's the left loop. Compare it to the pancreas. Which one is hyper-echogenic than the other? It's the pancreas, isn't it? Pancreas is hyper than the liver, the left loop of the liver. Do you understand? There's the liver. The liver passes here. It passes here like that. There's the left loop. The focus was on the left loop, comparing it to the pancreas. So you can see the left loop over there and the pancreas. Pancreas is hyper. But sometimes the pancreas can have the same echogenicity as the liver. As I said, depending on the fat deposit. So that's it. Now, if you come to, here, if you compare pancreas to the renal sinus, you should know that the pancreas echogenicity is less than the renal sinus because the renal sinus is white. It's white than the pancreas. You understand? This is not really important. Don't worry about the facts. But the renal sinus echogenicity is white than the pancreas. Let's understand that aspect. There is the renal sinus, the middle of the kidney here. Yes, that's the renal sinus. It's white as compared to the pancreas. All right. So who can tell me this part of the liver? Which part of the liver is this? Which loop? Which loop is this?
Yeah, the left.
Okay, the left loop. Because I didn't hear you earlier. That's the left loop. Once you see the loop elongated, like thin like that, then you know it is left loop, because the right loop is not that elongated like this. The right loop is big. It's not like this. So this left loop is at the epigastric region. Epigastric, you know, epigastrum, you know. So it's there. The left loop is there. You understand? The pancreas is just below it. So you can focus on the pancreas and capture it. Okay. So falciform ligament, I explained it last week. Falciform ligament is here. This structure here. It comes down. It does what? The main function of the falciform ligament is what? It's a ligament.
It divides the right loop and the left loop.
It divides the right loop and the left loop, and it also serves as what? An attachment to the anterior abdominal wall, so that the liver will be firm. Not only the falciform ligament, there are other ligaments that hold the liver firmly to the posterior abdominal wall and anterior abdominal wall. But for falciform ligament, apart from separating or dividing the left and the right loop, it also connects the liver to the anterior abdominal wall, so that it will be firm in the abdomen. Lobar fissure, so main lobar fissure. Lobar fissure, a fissure is like a division, it's like a line dividing, a structure dividing, it's a fissure. Or it can even be a cavity by dividing something. Do you understand? So it's a landmark that separates the right and the left loop of the liver. So that lobar fissure is done by the what? Falciform ligament. This lobar fissure. You see, which of the loops is here? Here. What loop is this, please? Who can tell me?
Yeah, the right loop.
The right loop. Good. Because you see the diaphragm nicely over here. The left loop doesn't have the diaphragm, clearly seen there. The diaphragm is bordering the right loop over there. Nicely. There's the diaphragm. Have you seen it? Nicely. This one, if you want to measure, some people, this one, if you stand here and you drag it to this place, you are not wrong. Some people, if they want to tell you that you are sick, meanwhile you are not sick, they'll stand here. Have you seen that the left loop has gone inside? So the left loop can come as high as here, this place. They can stand here and measure up to that place, which is wrong. We don't do that, because you have captured almost the full of the right loop. So why are you extending it from this part to the left side? No, that's wrong. Once you capture the liver like this, it's better you measure it this way than trying to measure the left loop, which even didn't show up. You have already captured the full right loop and you want to measure from that side to the left loop, which didn't show. If you do that, you overestimate the liver. Do you understand? So that's why I showed you some images earlier that the right loop, most part of it didn't show. All this part was cut off. And that one, you get the image in a way that the left loop will be shown, so that you can measure that one in addition. But this one, almost all the right loop is seen. So you cannot measure full right loop to the left loop like that. You overestimated. So always you have to know how to position your probe. It's very important. That's why I'm saying when you meet the students, when you meet Sir Williams, let him scan it for you to see and measure it for you to see. Because this is practical. And those who are working, let your bosses teach you. By now, I know you know how to go about these things. Okay, so this is the lobar fissure. So the falciform ligament, which divides the right loop and the left loop, can also serve as the lobar fissure, which is the division of the right and the left lobes. Ligamentum venosum and caudate what? Lobe. I don't know if any of you has heard of ligamentum venosum. or it has another name. It has another name. I think yes, I think it's the same, or ligamentum venosus. Ligamentum venosus is also there. You see, in embryology, blood circulation through the fetus, you understand? The oxygenated blood will be moving from the placenta, because it is the placenta that is serving as the fetal lungs. The fetal lungs are not working, like they are not mature to work. So the placenta will oxygenate the blood, pass it through the umbilical vein, not artery, umbilical vein. The umbilical vein, yesterday, when I was teaching you in the evening, you saw that the umbilical vein was passing through where the liver was, right? Because the umbilical vein will come, it will have to pass through the liver before it discharges it before it will get into the the veins will get into the inferior vena cava. You understand? With the help of the hepatic veins. But in fetal circulation, that umbilical vein will send the oxygenated blood, instead of it to go into the liver for the liver to grab it, and then the hepatic veins will now take it to the IVC. No, it doesn't do that because the liver is not fully mature to receive that blood. So there is something we call it's a shunt. When we say a shunt, you understand shunt. It directs the blood to a different angle. That's a shunt. You are shunting the blood. You are diverting the flow to a different angle, and that is ligament. That is ductus venosus. The main shunt is called ductus venosus. But when you grow, like when you are being born and you are growing, then it forms ligamentum venosum. So in embryology, here is not clear, right? Ductus venosus. There's the main term in embryology, in fetal development. There is ductus venosus. When the umbilical vein is sending the oxygenated blood to the heart, it will have to, ideally, it should come and pass through the liver, because the umbilical vein passes through the liver. But before it will get into the liver, there is a shunt over there that shunts the blood flow, not to prevent it from going to the liver, so that it will enter the inferior vena cava directly. And that shunt is called ductus venosus. It's like another tubular structure that shunts the blood flow, preventing it to go to the liver. Because once it goes to the liver may be damaged. The liver is not mature, so it may be damaged. That blood shouldn't go in there. Yes, scanty will go to the liver and cause some supply or but the liver is supplied by what? The hepatic arteries and the portal veins. You know it, we have done it. But in embryology, the blood circulation is a bit different. Yes, most of the veins are arteries. Most of the arteries are veins in embryology. Yes. So that shunt, that directed or diverted the blood away from the liver into the inferior vena cava directly. Then it will be sent to the right atrium of the heart. That shunt is called ductus venosus. But when you give birth and the child is growing, that ductus venosus has to close because blood will have to get to the liver. So it will now close and shrink. So when it shrinks, then we have the name ligamentum venosus. Do you understand? So it's something that was there, that was working when that child was, let's say, a fetus. But now that it is out, from the uterus and it is growing, that structure, which was ductus, will now change to ligamentum. Ligament. Just ligament. Ligamentum. So that is it. The venosum is about vein. It's umbilical vein. So ligamentum venosum. Okay. So somebody has written something. Let me check. Doppler what? Ductus venosus. Okay. So you mean you are using the Doppler to find it? Yes, that's it. In embryology, yes. If you are doing obstetric Doppler, then you can detect all these because it contains oxygenated blood. It shunts oxygenated blood to the inferior vena cava in embryology, please. Because vein does not contain oxygenated blood, but in embryology, in fetal development, veins rather contains the oxygen. You understand? So if you use Doppler, as Isa is saying, yes, you can pick it up. You understand? That is in embryology. When the person is growing, has been born, and the person is growing, that ductus venosus will shrink and now obliterate. So obliteration of the ductus venosus will form a ligamentum venosum. Okay, so the ligamentum venosum, that ductus venosus has turned to be ligament, and it will have a function. So ligamentum venosum separates the caudate loop from the left loop. You understand? Caudate loop from the left loop. I think we talked about these loops some time ago, I think last week or so. The caudate loop, quadrate loop, they are the accessory loops. So for you to know that this is left loop and this is the caudate loop, it is what? The ligamentum venosum that does that. So you can see the ligamentum venosum here. Very tiny here. These ligaments that we are talking about, they are not too evident that you put your probe out and the other you are seeing. Please, you have to search for them. Your machine also needs to be a bit powerful to see them clearly. So this is ligamentum venosum. So if you ask Sir Williams to show you and then it's not viewable, don't think it is maybe the person cannot view it. It's not like that. It's not all the time that you can see them clearly. Because we have individual differences. Yes. There are some people, those ligaments, actually, they are expected to shrink completely. But most people's own will tend to be what? Ligaments. And it will help. It will help do other things in the body. So this is it, ligamentum venosum. And we can see the caudate loop over here. You can see the inferior vena cava over here. All right. Now, liver pathologies. Liver pathologies. Before we start, can you mention some liver pathologies that you know of? For the regular class, if you are not able to mention, that means you have decided not to learn because I sent you the slides last 2 weeks. That means you have decided not to read ahead. You have the slides, right?
Yes, hepatitis.
You said
Hepatitis.
hepatitis. Okay, yes, that's true. That's true.
Hemangioma.
Hemangioma, very good. Yes, it's very common. So the graduates are now talking. You, those who are having the slide, you are not talking. Okay, let's start.
Hepatic adenoma.
Okay, hepatic steatosis, fine.
Sure, it's liver sclerosis facts.
Liver what?
Liver sclerosis.
Sclerosis. Sclerosis, it's a condition, but it's not something that we actually talk about like that. You understand? Actually, when we are talking about liver conditions on ultrasound, we don't mention it. Yes, because it's not anything that you can use ultrasound to pick it up.
Yeah, what about fatty liver?
Yes, fatty liver is part. It's very common in the alcoholics. Yeah. We will talk about all those stuffs. All right. Liver pathologies. They are malformations, new growth or changes in the tissue morphology of the liver, either micro or macroscopically, leading to reduction in or gross dysfunction of the liver. That's the definition. But you know how I set my questions. Me, I wouldn't ask you what is. So I can bring this definition, but I'll bring dash inside. Yeah, for you to put the words there. That's it. So there are malformations, new growth or changes in the tissue morphology, like the state of it, the shape, the size of the tissue of the liver. Either micro means small, or macro, big, leading to reduction in or gross dysfunction. Reduction in the function of the liver. The liver function has reduced. Or gross dysfunction, meaning the liver has lost about 70% of its function. Gross dysfunction. Do you understand? So these are just malformations. Malformations. Anything that forms abnormally in the liver is a malformation. Stigmata of chronic liver disease manifests when about 60 to 75% of the liver parenchyma is what? Destroyed. That's why I told you the last time that the liver starts to show the signs of liver disease when about 70% of the liver is damaged. You see, the liver, you can be there with a liver condition. You won't see anything. 50% of the liver will be damaged completely. Still, nothing will show because the rest of the 50% will be able to take care of your body. 60% will be damaged. Still, nothing will show. 70%, that time, then it will start. Mostly more than the 70. Then the signs will start. Do you understand? The liver is the only organ. The liver and the epithelial tissue, they are the only tissues in the body that they can regrow. Like regrow as in the liver. If you cut part of the liver has the ability to grow back. It has the ability to grow back where you have cut, provided where you cut wasn't too big. Yes. If you divide the liver into two and you slash half off, it's difficult to get it back. No. But maybe a tumor affects part of the liver, like a small part, 5% of the liver or something, and you cut it. It can grow back. Yes. Because the liver is very important. So nature made the liver that way. Do you understand? So before you see this, when we say stigmata of chronic liver disease, stigmata are the signs of chronic liver disease. Who can mention some signs of chronic liver disease? Chronic liver disease, like diseases that it's difficult to cure when it affects the liver. Difficult to cure. So when you have them, you start having signs. What are the signs? Stigmata of chronic liver disease. So if you start from the upper limbs, you call something Dupuytren's contractures. Go and read about them. It is your assignment. Go and read about the stigmata of chronic liver disease, please. Yes, go and read about them. It's your assignment. The regular class, I gave you some reading assignments last 2 weeks. I've forgotten to ask you, and I'm sure nobody read it, right? I'll ask you. Okay, so go and read about the stigmata, just punch stigmata of chronic liver disease. It will give you all of them. Yes, if you pick the upper limbs, we have them.
This part.
Yes, jaundice is part of it. That's the yellowing of the sclera. So you have to start from the limbs like this. You have to raise your hand like this and start from there. You understand how? So you start from your limbs. We have these muscles here, the thenar and the hypothenar muscles. They will be wasted. They will be wasted. Wasted means that a form. Then we have dupuytren's contractures, meaning you cannot do this. There will be contractures, fibrous tendons and ligaments over there. There will be contractures. Do you understand? If you come to the face, there will be yellowing of the sclera. Yellowing of the sclera, meaning there will be yellowish discoloration on the white part of the eye. Do you understand? In children, you see the tip of the nose also to be yellowish. Then it could also present with what? Anemia. So if you lift the tongue and check underwards, you will see pallor, meaning the person is pale. The blood is low. You understand? Then when a person talks on you, halitosis, we call it phytohepaticus. Phytohepaticus. Like the person, there is halitosis. There is what? Halitosis, bad breath. Also there. And then you come to, let's say, there are other stuffs, but then you come to the abdomen. If you come to the abdomen, there could be abdominal distension because of ascites. Abdominal distension could be there. Caput medusa, meaning the abdominal blood vessels, the abdominal wall, the blood vessels there will be dilated, and they will be dilated. When you go and read about all of these, you see, you see them. You see the caput medusa, you see them. Spider angiomas, you see it. And then you ask, what is it? Check Google images, not ultrasound. Just check Google images of them, not ultrasound image. Then you see them, then you appreciate that, oh, this is caput medusa. This is spider angioma. Okay, this is palmar erythema. You will see them, and then you will appreciate these things. When people come with chronic liver disease, the moment you see them walking towards you, sometimes the moment you see them walking, you know this is definitely chronic liver disease. The moment the person lies on the bed and you start talking to the person exposes the abdomen, you see that this is likely to be chronic liver disease because the stigmata are there. Stigmata. Pedal edema, pedal edema, or pedal swelling. You understand? When you examine, then you find the edema. But the moment you just look at it, then it is swelling, pedal swelling or foot swelling. You see it, and a whole testicular atrophy. The testes will shrink. Testicular atrophy. All these are stigmata of chronic liver disease. Please go and read about it. Stigmata of chronic liver disease. You can decide not to read that one. It's your own thing. But it's good to read about chronic liver. The stigmata is very good. I know why I'm saying that. Okay. You haven't gone for an interview before, so you finish and you want to work, and you're going for an interview. Okay. And even it's not for interviews. You have to know, as a sonographer, you have to know them. There are focal and diffuse liver masses. Liver masses, we have focal and diffuse. Focal means that they are like this. Focal has a focus. If this is the liver, focal, you see them like that. You see one here. You can see one here, like that. Focal. You can see them like separate from each other, and and they have focus. You can see that this is this, that is that, like that. But if it is diffuse, it's like this, like that. Diffuse is precessing like that. You understand? It's haphazard, arranged anyhow. That's diffuse. For focal, you see they have they are in focus. You see one is here, one is, you can even see only one. Only one lesion is what? Solitary lesion. Solitary. The word solitary means one. One. So we mostly use that to write reports. There is a hypoechogenic solitary lesion seen in the other organ. So that means it is one. You understand? So you have to know these terms so that your report will be nice. You don't write any report that you want. Report that when somebody reads the report, but report that when somebody reads the report, it should be nice to the ears. And you should use the terminologies. Do you understand? Okay, so, and all that we are doing, it comes with the terminologies. So the focal lesions usually tend to be benign, while diffuse lesions normally tend to be malignant. You know the meaning for benign and malignant, right? I think everybody knows. Benign means not cancer or not cancerous. Malignancy means it is cancerous. It is cancer. It has cancer cells. Do you understand? So if you see the lesions to be focal, the regular class, focal lesions, they tend to be benign. There's an OBJ question. They tend to be what? Benign. But the diffuse lesions tend to be cancerous. Okay. Even though it's not always the case, but in about 80% of cases, that is the case. So categories of the liver lesions, as I said, focal and diffuse. So focal lesions are usually well circumscribed. You see them nicely potted with a specific focus in the liver parenchyma. It is normally a solitary mass. That means one mass, but can be multiple. Example, hemangioma. Hemangioma is a benign lesion. It's a focal lesion. You see it mostly only one, solitary. It doesn't mean that you cannot see two. You can see two, but still focal because it doesn't present in a diffuse pattern. Okay. I think some people's microphones are on. Let me mute everyone. Okay, that's fine. So diffuse lesions demonstrate multiple foci within the liver. Multiple foci, meaning they can be distributed haphazardly, anyhow, if it wants, anyhow, and usually in multiple stages. Example is what? Steatosis. And we'll talk about steatosis. Now, subtle signs of liver masses. There are some signs of liver lesions or masses or tumors. There are some tumors in the liver that when you see, when you are capturing the liver, the tumor is there, but it may be difficult to see the tumor. And so it presents with subtle signs. Subtle signs means that the signs are not that, the signs are not that strong to see that this is a tumor, but you have to be smart and you have to develop your sonographic eyes to see that even though it is subtle, but you have to see that this is a mass because there are other things you have to check. So the subtle signs are contour deformity. Let me show you something. So have you seen this tubular structure here? This tubular structure, please, is it curved or it is straight? Do you see it curved? It's curved, right? So that is tell you that there is something here. There is a mass, very clear mass, but it's a subtle lesion. If you don't check it well, you will know it's a mass. There is a mass. And the mass is the one that is pushing it and curving the tubular structure. That's a subtle mass. You have to be, you have to focus very well and know that this is a mass. Yes. don't always focus on the echogenicity, but also focus on the structures, the tubular structures. If they are supposed to be straight and they are curved, know that there could be something pushing them. Think of it. Okay. Then there is a mass here. There's also a subtle mass. Subtle means that if you don't watch it keenly, you will miss it. You won't see it. That's a subtle mass. So you can see that this tubular structure here is big, and the width is big, but here, have you seen it is closing? It has closed this tubular structure. It has closed it over there. And that should tell you there is something pushing it. There is something pushing it. Yes, linear probe can view these stuffs, but of course, linear probe will make it so big. If you don't take care, you may not appreciate it. Because linear probe, this mass like this, linear probe can see like this. So if you don't take care, you may think it is normal liver tissue. So it's better you always utilize both probes. Use both probes. First, you have to use the curvilinear. If you are seeing something that you think this may be abnormal, then you now switch to the linear. At that time, you have, you have positioned your mind on it that indeed there is something abnormal. So let me use the linear to confirm. Yes, but if you go and use linear first, you may miss these things. Yes, you have to use always for deep structures. Use curvilinear first. Then, if you think you have to use linear, then you can switch and also use linear. But linear normally will let the thing so big. And this lesion is not about the size, but about the echogenicity. So it doesn't mean that when you use linear, you cannot miss it. You can miss it because it's about the echogenicity. Echogenicity of the lesion to the liver is almost the same. So you have to be very smart to know that the lesion they are compressing tubular structures. And then you find out, you know that there is a lesion which is closing these tubular structures. So let me check it well. And then you know the borders of the lesion. You understand? So subtle liver masses, there is slight change in echogenicity, mild architectural disruption. Mild, meaning you are not going to see gross changes. There will be a displacement, compression, or bowing of a vessel. So the vessel, bowed vessel, I've shown you some, that somewhere bowed, like it's closing up, somewhere distorted. You understand? Critical edge shadows emanating from the rounded border of a mass. Not all masses will give shadows. Will give edge shadows, not all masses. But some masses will do that. They will give edge shadows. Edge shadow means that if this is the mass, the edge here will create some shadows here. This edge will also create some shadows. So when you see that, know that there is a mass that is casting those shadows. Then there will be rounding of the inferior edge of the liver, deformity of adjacent organ. Rounding of the inferior edge of the liver happens when the mass is very huge. When the mass is huge, then you see that if this is the liver, let's say this is the liver, and the mass is very huge and it is round over here, you see that the inferior edge of the liver will appear rounded because of the mass over there. So that's it. It depends on the size of the mass to see those structures. So you can see these are multiple masses. You can see one mass here, one mass here. Sorry. You can see one mass here. If your sonographic eyes are not developed, you may think that, hey, but is there anything like that? They are there. They are really there. They are there. So keep practicing. If you keep practicing, your sonographic eyes are going to be, on point. You understand? Please, what part, which loop of the liver is this? Who can tell me? Which loop of the liver is this?
The left loop.
The left loop, because it's elongated. You can see it. But the masses have made it big. The masses have increased the size of the left lobe over there. Now, we'll go through all these liver conditions. That's why I said that when we are able to complete, the regular students, when we are able to complete one of your courses, then we have to meet twice a week for this advanced course because it's a lot. And I don't want to leave many of it. I don't want to delete some of the slides because you need them. So you have to also read ahead. It's better so that you would understand stuff easily. Okay. Now, the benign lesions are hepatic hemangiomas, focal nodular hyperplasia, benign liver cysts, hepatic adenomas. It comes all the way to focal fatty infiltration. Then the malignant lesions, which are cancers, are the hepatocellular carcinoma, cholangiocarcinoma, hepatic lymphomas, and liver metastasis. All these are also cancers. So we have to go through all of them. So when it's 7:30, you remind me and then I'll end. So benign liver lesions, hepatic hemangioma. It's a non-cancerous. You see, once we hear hemangioma, the HAEM, hem, is blood. Angi is blood vessel. Oma is a tumor. Do you understand? Blood vessel, tumor. So it means that we are saying there is a tumor forming within a liver blood vessel. Tumor forming within a liver blood vessel. That is hemangioma, hepatic hemangioma. Hepatic is the liver. So it's a non-cancerous liver tumor composed of a mass of abnormal blood vessels in the liver. It is fed by the hepatic arteries. It is fed by what? Hepatic artery. Most common benign liver lesion. Please, you see, when we say something like this, nobody should tell you that this is examinable question. Which of the following is the most common hepatic lesion? It is hepatic hemangioma. Nobody should tell you. It's the most common benign liver lesion. When the question says most common malignant liver lesion, then it is not hemangioma because hemangioma is not malignant. Do you understand? Okay. And it is also the second most common incidental liver lesion. Like the person is dead, nothing is wrong with the person. The person is going for screening. Nothing is wrong with you and you are going for screening. Some people are doing screening, then you are going for it. When you get there, they take a scan and they notice that you are having hemangioma. It's an incidental finding. It wasn't giving you any sign or symptom. Incidental finding. It's the second most common incidental liver lesion. Women get it more than men. That's what you have to understand, please. Women get it more than men, and it could be from the levels of estrogen, because estrogen has a potential of forming new blood vessels. Estrogen, yes, and that one can form abnormal blood vessels, which forms hemangioma. Vascular blood filled with filled spaces. Yes, you see the blood vessel, blood will be inside, all right, but the blood flow in them will be slow. Will be slow because they are abnormally formed. Do you understand? Then most of the time hemangiomas are solitary, like one. Do you understand? One, like that. That means solitary, but they can be multiple. They can be what? Multiple. So 10% are multiple. few enlarge, few regress. Few enlarge, few regress, meaning that if it is there, it's unlikely that the hemangioma will regress by itself. And mostly too, the size that you get it today, 1 year time you measure and it may be the same size. So it doesn't mean that it can grow large. It can, but we are saying that few do that. Few. On USG, it is displayed as distinctly bordered hyperechogenic areas, but with no posterior shadows. On ultrasound, once you are scanning someone and you see this lesion, you see it's hyperechogenic lesion in the liver. Straight away, it is hemangioma. Nobody should tell you this. It is hyperechogenic. Hyper what? Echogenic. Even though we have the atypical hemangioma, which I think I'll talk about, but this is the typical one. From head to toe of it is white. This one, you can see the hemangioma. It can be tiny like this. Hemangioma. White, it doesn't cast shadows. Take note, it doesn't cast shadows. So classical. So classically, about 60 to 70%. Actually, when you're writing reports, this is what you have to use. It is displayed as a distinctly bordered hyperechogenic mass, but with no posterior acoustic shadowing. It's homogeneous lesion. It is hyperechoic and it's mostly less than 3 centimeters. That is hemangioma. Mostly less than 3 centimeters. Almost always less than 3 centimeters. That doesn't mean that you cannot get some that can go beyond 3. That's what we call atypical hemangioma. Atypical. So have you seen it? The hemangioma is here, very nice. Have you seen it? Where my cursor is, hemangioma, very nice. This one. And have you seen that this image, it has captured the full liver? Have you seen how it has captured the full liver? So this is a full liver over there. But this liver, I don't know, it may not be an adult liver or it may also be an aged liver. You understand? After 60 years and cool. Yes, sometimes the liver size will reduce. And or it could be that the person has reduced the zoom, the magnification. Yes, you can reduce it for it to appear smaller. Yes, that doesn't mean it will affect measurement. No, the zoom button doesn't affect measurement. So this is hemangioma over here. Please, this is image A. This is image B. Which of the liver loops are the hemangiomas found? Tell me.
There with the image B, it is found at the right side of the liver. And the image A, it is found at the left side of the left loop of the liver.
Left loop of the liver. Okay, yes, that's right. Okay. All right. So atypical hemangioma presents with hyperechoic borders but hypoechoic center. So the borders will be white, but the inside will be dark. That is atypical hemangioma. Atypical. So if you see this lesion over here, this one, you can see that the borders are white. The borders are white over there, even though not purely white, but the borders are white. But the inside cannot be compared to the borders in terms of the whiteness. This one, you can see this one too. The borders are white over there, but the inside is not that white. And those are the atypical hemangioma. This is in the left loop, and this is likely to be in the right loop. because I'm seeing the diaphragm also there. So we describe it as hyperechoic rim with hypoechoic center. The rim is the borders. We have lobulated border. Yes, large variable echogenicity associated with fibrosis. So it can be large. The typical hemangioma should mostly is less than 3 centimeters. The atypical can grow more than 3 cm. The atypical can grow more than 3 cm. And it's associated with fibrosis. Fibrosis means hardening of the tissues. The tissues become fibrous, hardening of the tissues. It's also associated with hemorrhage. Don't forget that hemangioma is what? Tumor of abnormal blood vessels. Like abnormal blood vessels form that tumor. So blood is flowing through them. It can rupture. It can what? Rupture and bleed. So the atypical hemangioma are known for that. They can rupture because they can become big and rupture. So hemorrhage, bleeding. Thrombosis, meaning there could be what? Obstruction, which blood, they also clot. Thrombosis is formation of blood clots. Since it deals with blood vessel, blood can clot in there. Necrosis is what? Tissue death. When the tissue is prevented from getting enough oxygen because the thing is abnormal blood vessels. So blood may not be able to pass through them well to supply the other parts blood. And so it could undergo necrotic changes, meaning the tissues in it may start dying. And that can cause it to rupture because it will become soft and rupture. So that is hepatic hemangiomas. Let's move to adenomas. Adenomas are called hepatocellular adenomas. We are talking about the liver ones. Because adenomas can occur almost in any gland. Any gland. The liver is also a gland because the liver also produces some hormones. Yes, so it's regarded as a gland also. Yes. So adenomas can occur in the ovary, the pancreas, adrenal glands, any. All right. So in the liver, we call adenoma hepatocellular adenoma. They are benign, generally hormone-induced liver tumors because it's about hormones. So they are hormonally what? Induced. The tumors are usually solitary, meaning one, have a predilection for hemorrhage, meaning they can rupture and cause bleeding, must be differentiated from other focal lesions. You have to be able to differentiate adenoma from other lesions. It is rare, but can be fatal, meaning adenomas are not common. The word rare means it's not common. But when you have it, since it can easily rupture, you can die because once it ruptures, you bleed into the peritoneum and you die. By the time you realize you are collapsing. So when you are able to tell that this is liver lesion, which looks like adenoma, the doctor will request for, or you can request at the end of your report, recommendation for what? Histopathology. What is histopathology? Histopathology means that they have to go, send the patient to a specialist who deals with, picking structures from the body and view them under the microscope and tell us that this is cancer or not, or this is this particular mass, this is this particular mass. They're able to tell every mass when they take part of the tissue from the mass and send it to the lab. Do you understand? So that's histopathology. So when they view it under the histopathology, they don't see what we call Kappa cells. Kappa cells are they are soldiers. We call them macrophages. Macrophages are soldiers of the body. In other words, if you have heard of monocytes before, monocytes will differentiate to form macrophages. So macrophages are part of white blood cells. You know monocytes are white blood cells. So when they differentiate to form macrophages, they are also white blood cells and they fight infection. So in the liver, macrophages in the liver they are called Kappa cells, Kappa. And with the adenoma, when the histopathologist view the adenoma under the microscope, they don't see Kappa cells. And that should tell them that this is what? Hepatic adenoma. No Kappa cells. It's associated with women. Women, not only women, but men also, by women birth control pills. So we are saying it is hormonally responsive. So if you are a woman and you keep taking contraceptives, you prone yourself to these things, especially the estrogen-derived ones. Estrogen-derived ones. Men, anabolic steroids. Men will be going to the gym and want to develop muscles quickly and will be buying steroids. The drugs that will help you develop muscles, they are steroids. They are steroids. So it will also cause you to develop hepatic adenoma. Children, glycogen storage disease. So we have a condition called glycogen storage disease. Glycogen, you see, when you eat, the excess glucose will have to be stored. The body will not throw it away. It will have to be stored. And how you store it is the body will convert the glucose into glycogen and store it. But there are some children that don't have the enzyme for that. So they are not able to convert it. So we call it glycogen storage disease. So those children that have that condition are also prone of having hepatic adenoma. It's a risk factor. Have you seen the adenoma? It's a subtle mass. Subtle mass. Please, okay, I think the arrow is even there. Have you seen the adenoma here? It's clear. This one is very clear. That's the adenoma. Compare the echogenicity here to this place. Compare here to here. It's different echogenicities. This one, very clear here. Are you not seeing the adenoma here? And there is bowing of this vessel. Have you seen it? It has closed this vessel. This vessel is coming like this, and it has closed it here. Here is closed, like that. There is a mass, subtle liver, feature. It should tell you that there is a mass over there. That's adenoma. Adenoma is, if you're not careful, you miss them, because the echogenicity is isoechoic to the liver. It's almost the same as the liver, so you may miss it. So you have to be, as a sonographer, that's why when you are someone is scanning and making core at the same time, it doesn't make sense. You are scanning someone and you are making core. Please, these things, you miss them, you won't see them when you are making core. You are double concentrated. How can you see this? Do you understand? Put your phone somewhere whilst you are scanning. Put your phone somewhere. If you are making call, just take permission from the patient and make your call. Afterwards, start again. That's all. All right. Now, focal nodular hyperplasia. This is actually the second most prevalent tumor of the liver, benign tumor of the liver. I've told you that hepatic hemangioma is the first common benign lesion of the liver. Focal nodular hyperplasia is the second most common benign tumor of the liver. It's a benign tumor of the liver, which is the second most prevalent tumor. The first is what? Hepatic hemangioma. It is usually asymptomatic, rarely grows or bleeds, and has no malignant potential. Asymptomatic, it wouldn't give you any symptoms. So it is also detected incidentally. It is detected what? Incidentally. Let me go back and check something for you. Second most common incidental liver lesion. That is what? Hepatic hemangioma. Second most common what? Incidental liver lesion. But when you go to the focal nodular hyperplasia, it is the first most common incidental liver lesion. But when we say the commonest benign lesion, that is hepatic hemangioma. The second most common is focal nodular hyperplasia. But when you see incidental Incidental means that it doesn't cause any symptom. You are there, you are going for screening, and we see it. Incidental, that means that the hepatic hemangioma is second, but focal nodular hyperplasia is first, the incidental. So that is it. And we are saying that it doesn't bleed as compared to the hepatic hemangioma that can rupture. It doesn't bleed. It has no malignant potential, meaning it cannot change itself to cancer. It is thought to be the result of increased hepatocyte number caused by hypoperfusion or hyperperfusion from anomalous arteries within the hepatic lobule. When we say hypoperfusion, you see the cells have to receive enough blood. If they are supposed to receive, let's say 80% oxygen, let's say 80% oxygen, they are supposed to receive at least 80% oxygen. But now they are receiving 40%. That should tell you it is what? Hypoperfused. Hypo, low blood supply to the structure. Once there is low blood supply, we know that oxygen level is low because blood carries what? The oxygen. So once blood is reduced, oxygen level reduces. Do you understand? So hypoperfusion means that inadequate supply of blood to the organ. That will cause you to develop focal nodular hyperplasia. The word hyperplasia means what? What is hyperplasia? Hyperplasia, who can differentiate hyperplasia from hypertrophy? Hyperplasia and hypertrophy, they are not the same.
Hello, sir. Let me try. Is that I think one is the size and the other is the growth of the cells or something.
I see. Maybe, yeah, you have the idea though, but not really full definition. Who can help? Hyperplasia is the increase in the number of cells. If the cell number is supposed to be 10, I'm giving an example, it's supposed to be 10, but now they are increased to 30, 40, 50 and above. We call it hyperplasia. The cell number have increased. What about hypertrophy? Increase in the size. The cell is supposed to be 10. It is still 10, but the size is supposed to be this. But now one size is this, but they are still 10. That's increase in the size. That's hypertrophy. It doesn't increase the number, but the size. Hyperplasia is increase in the number. Do you understand? So each of them, both of them, will cause the organ to be enlarged. Both of them will cause the organ to be enlarged because if it increases the cell size or increase the cell number, it causes enlargement. That's it. So focal nodular hyperplasia, a node is just single tumor. A node, it can be very tiny tumor. That's why we call it nodular. Focal means it has a focus. It is not diffused. It can be there, only one. Then you see it. Yes. So we are saying that it happens when there is hyper or hypoperfusion. Hypoperfusion, there is inadequate blood supply to the structure. Ideally, the structure should rather shrink, but the structure will now try to adapt to the situation. And in its adaptation, it will call upon other things to help it enlarge itself so that it can adapt to the situation. That will cause it to form the tumor. Hyperperfusion, the flow is so much for the structure. If it's too much for the structure will still try to adapt. And in it trying to adapt to the condition, it may have to undergo hypertrophy. For hypoperfusion, there is what? Hyperplasia, increase in the number of cells. For hyperperfusion, there is hypertrophy. So both of them will cause some enlargement over there. Do you understand? and it happens in abnormal arteries, forming the focal nodular hyperplasia, which you see it as what? A tumor. On ultrasound, you see them as variable sonographic appearance. Variable means that part can be anechoic, part can be hypo, part can be hyper. Variable. Characteristic central stellate scar. Yes, you see the lesion and you are seeing a scar in the lesion, white stuff inside at the center. That should tell you it is FNH. FNH, what will help you know that this is FNH is the central stellate scar. Not associated with birth control pills. It's not like the adenoma. Adenoma is associated with birth control pills. This one is not associated with birth control pills. One thing they use, the histopathologist uses to tell the difference between FNH and adenoma, hepatic adenoma. When I say FNH, it's focal nodular hyperplasia. That's how we call it at the hospital setting. FNH. Yes, so FNH and hepatic adenoma, the difference is that hepatic adenoma has no Kappa cells. The macrophages are not there. In the lesion, when they check it under the microscope, they don't see macrophages. The Kappa cells, they don't see it. But with focal nodular hyperplasia, there are Kappa cells. That's the difference. So, but that one is not your thing. That one is for the histopathologist. But we are teaching you, so we have to mention. Low risk of hemorrhage because it's not known to rupture. They show centrifugal flow on color Doppler interrogation. Please, centrifugal means what? I taught you last week or last 2 weeks. What's the meaning of centrifugal? Is it moving towards the liver or moving away from the liver?
Moving away from the liver.
Good. Centrifugal, moving away from the liver. Okay. So when you put your Doppler on the focal nodular hyperplasia, you see the flow moving away from the liver. Focal nodular hyperplasia. Have you seen the central stellate scar? You see, this is the lesion. Very nice lesion over there. Very nice lesion. This is the central stellate scar. This is it. A scar appears white. That's the central stellate scar. This is a very huge lesion. I'm not seeing the scar within. That does not mean that it is not FNH. Yes. It could be that when you stand well and you position your probe well and you press well, you may see the scar inside. But there should be a stellate scar here. It appears like it's even trying to form, but it's not that clear in there. But for FNH, central stellate scar is the one you use to differentiate from adenoma. Very important. Or else you can also diagnose this. If you see this particular image, you can say it is hepatic adenoma. Nobody will do anything to you. Then your differential, you write FNH. Fine. But remember that the hepatic adenoma is uncommon. So it's better you write the common one as your impression and the uncommon one as your differential. Simple. So the common one will be focal nodular hyperplasia. They look alike. So you should put that one as your impression. Then your differential will be what? The hepatic adenoma, because that is not common. Do you understand? If you don't see the stellate scar, but once you see the stellate scar, it's pathognomonic. When we say pathognomonic, it means it confirms the mass, that the mass is what? FNH. FNH. So when you put your flow, you see that the flow will be moving away. This is an image, it's not video, so it's difficult to see where it's moving towards. It's not video. But you should know that there was centrifugal arterial flow. Okay, so this one you can see the lesion here, right? Have you seen the central stellate scar, the white inside? That is why we are saying it presents with variable echogenicity. Variable. But adenoma doesn't present with variable echogenicity. It is subtle. It looks like the liver parenchyma. Do you understand the few differences with them? Okay. Liver cirrhosis. What's the time? I think the moment I finish with the liver cirrhosis, I have to end. Because liver cirrhosis alone can take like 15 minutes or so. Please take note of the liver cirrhosis. It is a condition that you can meet it every week currently. So far as men have decided not to stop taking alcohol, and women have also decided, not only women, men and women have also decided not to stop fornication, and they are distributing hepatitis virus to each other. Liver cirrhosis will always be present. Don't forget. Okay. There's a condition that the regular students, about 50% of my questions will come from here, liver cirrhosis, because it's a condition that you don't have to mess. Please, it's a condition that is very important currently in our society. Very, very important. Among all the liver conditions I'll talk about, cirrhosis is the one I need you to master. Like if you're even sleeping and we ask you a question, you have to answer it in your dreams correctly. It will surprise you to know that when you start working, you will be meeting them like that. Cirrhosis. Liver cirrhosis is a complication of liver disease, and it is part of chronic liver disease. Liver cirrhosis is a chronic liver disease, CLD, chronic liver disease, that involves loss of liver cells and irreversible, listen, that's the most important too, irreversible scarring of the liver. Scarring means kutran, scar, kutran. So if you have your liver and scars are forming in the liver, what will happen to the liver? Scar is not a functional tissue. Scar is not functional, meaning if the liver cells form scar, that means that part of the liver is not working anymore. So if you keep on drinking alcohol, alcohol has the potential of destroying the hepatocytes, that's the liver cells. Alcohol will destroy the cells. Once the cells are being damaged, you see, right now, when you are doing something and you get an injury on your skin, within 1 week or 2 weeks, what will you see? When you get a small injury on your skin, within 1 week or 2 weeks, what will you see there at that site? What do you see there? We have all been injured before, so tell me what you see. When you get an injury today, you see scars, right? A scar, or if the thing was multiple, you see scars. So now the alcohol, the cells are so harsh to the liver, it destroys the liver cells and it causes injuries to the cells. So as the cells are injured, they have to heal. And as they are healing, they are leaving scars. That is it. As they are healing, they are leaving scars over there. So if you keep on drinking the alcohol every day, the liver is so strong that it can sustain you for you to drink alcohol for even 40 years before it will finally fail. Because as the cells are being injured, other cells are there, and the liver is able to also produce new cells. That is it. But when I was so then you are drinking too much alcohol, because alcohol, if you drink once in a week, there is no way that the liver may fail. I'm not saying go and drink alcohol. And if you drink, some people drink, I mean, the first thing in the morning, alcohol, afternoon, alcohol, evening, alcohol. If you do that, what do you expect the liver to do? Even that, the liver can still sustain you for many years, more than 20 years, 30 years, before you develop chronic liver disease. So have you seen how strong the liver is? But when I was so damn, so he didn't listen to all that the medics are saying. So that is it. Viral hepatitis B and hepatitis C. You see, some years back, hepatitis B alone was in Ghana here, especially West Africa, hepatitis B alone. But now, hepatitis C, if you joke, you are dead. Don't forget, we don't have vaccine for hepatitis C. We don't have vaccine for hepatitis C. So if you think you have gone for the hepatitis B virus vaccine, and so you're having sex anyhow, take note, the C is there. The C is there. But one thing about the C is that when you get the C, the body can easily fight it and cure it without you knowing that you have the C. But remember that if at that time, maybe you were having like malaria, your immune system was down, and you had sex and you got hepatitis C, at that time, the body cannot fight. The hepatitis C can overshadow your immune system, and that is all. And hepatitis C will cause hepatocellular carcinoma, like the cancer of the liver. It will cause it so quick than the B. But the good thing about the hepatitis C is that the body can kill the virus without you knowing. But if the body fails to kill the virus, then, and you didn't go for screening for them to tell you that you have the condition so that we put you on drugs, then remember, it will cause the cancer quick than the hepatitis B. Some people can have hepatitis B for 10 years without cancer, 15 years without cancer. The B, not on drugs. But somebody can also have the B, and in 5 years, the person is developing cancer because that person is also drinking alcohol at the same time. The hepatitis virus is destroying the hepatocyte and it is causing scarring. And you're also drinking alcohol, again, causing scarring. What do you expect? What do you expect? Even though I haven't come across someone that is having hepatitis B and C at the same time. I don't know why. Maybe we have to ask the lab guys whether they have seen such before. I haven't come across any. I have to do research into that. Maybe if you have the hepatitis, I don't know, but it doesn't mean that when you have the hepatitis B virus, you cannot get the C. It doesn't mean that. But I haven't come across someone with both B and C. We all can read about that. Yes. So that is it. You understand? Then fatty liver disease. Fatty liver disease is also one of the cause of liver cirrhosis. So the scarring is the cirrhosis. The scarring is the cirrhosis that we are talking about. The cells that have been injured in the liver will form scars, and that's the cirrhosis which is forming. The fatty liver disease is when there is fat deposit excessive fat deposit in the liver. And excessive fat deposit will now cause the immune system to what? Exaggerate inflammatory process. It will start inflammation because fat. That's why obesity is not good. If you're obese, small thing, then it will cause inflammation. Small thing, inflammation. So fat will cause inflammatory processes like that and start destroying the liver cells. So we don't need to have a lot of fat deposited in the liver. So if you have a lot of fat, you see a lot of cholesterol in your system, you'll see some changes, palpitation. You'll be there and your heart will be beating, then it stops. Like it goes to normal, then like that. Sometimes you will be having numbness. Meanwhile, you are not sleeping, you are not seated, or sometimes the moment you sit, part of your body will be numbed. Those things should tell you that there is the likelihood that you may be having high cholesterol in your system. It doesn't mean that all the time. Sometimes it is your nerves. It's your nerves that are not getting enough vitamins. Sometimes it's your nerves. Yes, which we call it neuropathy. But most of the time too, the blood vessels, you have too much fat. So it has what deposited in the blood vessels. So blood is not able to move well in the blood vessel. So you start developing tingling and numbness. Then they will be saying anansi acheme. Where is that anansi thing? So you have to know that too much cholesterol can also present with that. Those things. And cholesterol is fat. People eat fried rice at 8 p.m., 9 p.m., and they are eating to sleep. The moment they eat, they are sleeping. Sometimes I think about it, I don't just understand. You eat fatty foods, and 9 p.m. you're eating fatty food, and the moment you are done, you are sleeping. What do you expect the body to do? I don't get it. What do you expect the body to do to help digest that food for you? Eat early. 5 p.m. you eat fatty foods, fine, nobody cares. At 9 p.m. and 10 p.m. you're eating fatty foods, fried rice with chicken. I don't want to mention any place. There is one place where you go and buy chicken there, it's something else. You are eating and you are dying because the fat is too much. Please reduce that. Fat is important. Fat is good for the body, but reduce it. There are some people, they don't eat too much fat, but there is an enzyme which we call HMG-CoA reductase. That enzyme will produce the fat for you, what if you like it or not. The moment you sleep, it is nocturnal. The moment you sleep, it starts producing a lot of fat, a lot of cholesterol for you. Doctor has told you, don't even eat this food, don't eat this, don't eat this. But you're not eating, but still your cholesterol level is always high because there is what counter mechanism. Sometimes that enzyme is producing too much abnormality of the gene. So you have to be on anti-cholesterol for the rest of your life, like that. So these things, if you don't regulate them, they can cause continuous inflammation in the liver. Fat deposit in the liver can cause continuous inflammation and cause scarring of the liver. Do you understand? Okay. So those are the commonest causes of liver cirrhosis. Each time the liver is injured, whether by disease, excessive alcohol consumption, or another cause, it tries to repair itself. If the injury becomes consistent, extensive scar formation occurs. It's like you have gotten an injury to the skin. The skin tries to repair and heal. Once it heals, scar forms. Simple. And that will reduce the function of the liver. We have stage 1 up to stage 4 liver cirrhosis. So when you're writing reports, don't just write liver cirrhosis and you are done. What report is that? Tell us the stage. Depending on the stage, depending on what you see, will tell you this is the stage that the person is on. Once we get to the stage 3 and 4, it's becoming deadly. For stage 4, nothing can be done. The only thing that it can be done for stage 4 is what? Transplant of the liver. Remove the liver, bring another liver. That's stage 4. Now, stage 1 involves some scarring of the liver. There will be fibrosis. You see that the scars start forming, but you are not going to see the scars that much. At that time, the cells are now becoming hard because scar is hard. That is fibrosis. That one, at that time, the liver is still normal. The liver is still seen as normal. You may not pick it up. You may not pick the cirrhosis up. You understand? You may not pick it up, but if you do the sonographer, you know that the person is hepatitis B positive or is a alcoholic. It will prompt you to screen the liver so well, to probe the liver so well, to find out if it is stage 1. Because definitely you may see some little changes with the liver. You may see the scar will be few. But if you don't take the history, what dream cohort? So you may still think that the liver is normal. Take history. Have you ever been diagnosed of any liver disease? like hepatitis, just mention it. The person will say, oh, yes, yes, yes. Some years back, yes, they told me. And some sonographers cannot mention hepatitis. How they mention it, not even just sonographers. Many people, they mean hepatitis. What is hepatitis? Hepatitis. So you take the name and you mention. You understand? Okay. So we are saying that for the stage 1, few symptoms or even no symptom. Few symptoms or no symptom at all because the liver is still functioning. I told you earlier that the liver has to be damaged 70% before the stigmata of chronic liver disease will start. So this stage is considered compensated cirrhosis, where there are no complications. When we say compensated, take it from me, compensated means that the liver, even though something is destroying the liver, but the liver still functions. It still functions. And when you give medication, it can resolve. That is at the compensatory stage. Anytime you hear compensated cirrhosis, it means that cirrhosis can what? Be reversed. Like that liver condition, mostly cirrhosis itself is difficult to reverse. But that liver condition, which is causing the cirrhosis, can be what? Reversed. Be reversed. It can be reversed. Anytime you hear compensated, take note that that condition can be cured. The cirrhosis itself may not be reversed, but if it is hepatitis B, which is causing the cirrhosis, we can stop the progression of the hepatitis B. So the cirrhosis will not continue. So the condition, the stigmata of the chronic liver disease will be reversed. Someone having the abdominal distension, the ascites and co, sometimes it can be reversed. But remember, the moment you see ascites, even though sometimes it can be reversed, but ascites is decompensated. Decompensated is at the ascites stage. Once you see ascites, it means that the liver, about 75 to 80% are already gone. It's gone. So at that time, it's difficult to reverse it. But those people who come to the hospital early, sometimes we put them on drugs, and the ascites can resolve, and the liver can, come back to a bit normal, which can sustain the person for a bit longer. But if you wait in the house for your abdomen to be big, all fluid, at that time, it's highly decompensated. There is nothing anybody can do. The only thing we do is that we drain some of the fluid for you to be able to breathe well. You understand? But we know that whatever you do, you die. You die. It may not be that same week or same month, but you die subsequently. It wouldn't take long. You die. So stage 2 cirrhosis is also compensated cirrhosis. It's also compensated, meaning the moment you stop the medical insult. What is medical insult? The medical insult is the condition that is causing the cirrhosis. If it's a hepatitis B, alcoholism, hepatitis C, or what, the moment you start giving drugs to the person to stop, if it's alcoholism, then it's not about drugs, it's lifestyle. The person has to stop the alcohol. You cannot stop it abruptly, but the person has to stop, tap it down, and stop completely. If you stop the person for once, someone who has been drinking alcohol for continuously 10 years, if you stop the person once, the person will go into something we call alcohol withdrawal syndrome, and that one can kill the patient quickly. If you stop the person from alcohol, that I won't let you drink it again, you kill the person. Quick, please, you kill the person. That's why we don't cut it like that. You can give the person the alcohol. Even nowadays, we have some drugs that even mimics alcohol that you can give. But if even it's not there, you can still give the person alcohol, but not the level that he drinks. So you reduce it. If he drinks 50 ml, you reduce it to 30 ml. Then the next day you reduce it to 20 ml. The next day you reduce it to 10 ml. Then the body will be adapting. You understand? Then maybe 1 week time you reduce it to 10 mils, then you bring it to 5 mils, like that. I'm giving an example. So after 1 week going, you see that the body is now that aggressive for alcohol. So you now can bring it to 2 mils, and finally you stop it. That's how we stop those alcoholisms. If you stop it one day, you take it every day, morning, afternoon, evening. That's how you have been taking alcohol for 10 years. And you one day stop it. No, the body will never allow you. You'll be shaking, giddy giddy, you go and drink. If you don't drink, you go into alcohol withdrawal syndrome, and that one can kill you within minutes. So those alcoholics, the reason why many people cannot stop drinking the alcohol is the alcohol withdrawal syndrome. They tell themselves, I have stopped, but no, they try to enter into the syndrome. Once they try entering, they will quickly go and drink because they will die. If they enter into it, they will die. They'll be shaking like that. Same thing applies to cigarette. Those who have taken cigarette for long, if they don't take the cigarette, they cannot even go to toilet. If you know some, you can ask them. Yes, they have to be smoking, then they'll be able to pass physics.
That is true.
Yes. It's the chemicals in the cigarette. The body has adapted. So if you take them off one day, then you take them off. By the time you come back, the person is dead. The person is dead. Please. So don't judge them that much. We have a way of taking them out from it. Okay. So the stage 2 is still compensated, meaning once you give, if it's hepatitis, you give drugs to the person, the hepatitis virus weakens. It's not replicating again. The liver will start coming back to normal. That means that it's compensated, but the scars that have formed, the scar will not come back. We are closing. Yes, we are closing soon. I want to just finish with this, and then somebody's asking a question. Okay, let me finish. I'll answer you all those questions. With the stage 3, so with the stage 2, what you're going to see is that worsening portal hypertension and development of varices. I gave you the portal diameter, portal vein, 13 to 15, or it should be less than 15 mm. It should be less than 15 mm. But with portal hypertension, it dilates. You get it like 18, 19, 20 when you measure the portal vein. That means portal hypertension. You put your Doppler to check the velocity, and the blood flow is slow, very slow, because it has dilated too much. The velocity is what, 12 to, I think, 20. But when you check the velocity, you get less than 12, meaning there is portal hypertension. Do you understand? Then the diameter is different from velocity. Diameter is just the cavity of the portal vein, and that should be less than 15 mm. But the velocity is the speed of the blood flow. So that one, you use Doppler. When you measure, it should be 12 centimeter per second to 20 centimeter per second. That's the normal. But if it comes below 12, it is portal hypertension. Then you have gotten into stage 2. Stage 3, portal hypertension will increase too much. It will increase. So stage 3 is decompensated, meaning at that time, there is nothing like going back. You can't go back. We only manage them because we know they will die. They will subsequently die. We know. And what will you see to say that the person is in stage 3? Involves the development of swelling in the abdomen, that is ascites. Ascites is accumulation of fluid in the abdominopelvic cavities. And advanced liver scarring. The stage 2, we saw scarring, but it wasn't as many as the stage 3. Stage 3, the scarring is a lot. The liver becomes white, scars throughout. This stage marks decompensated cirrhosis, meaning there is no going back. So whatever you do, you die unless you go and see your prophet. Fine, we all believe in God, but with medicine, stage 3, no. with serious complications and possible liver failure. Serious complications, ascites, SBP, you have pedal swelling, like a whole lot. You see, stage 3, don't get there. Don't just get there because it's a serious issue. Once you get to stage 3, your days on earth are numbered. Once you get to stage 3, it is numbered. So you start giving yourself to your maker because the days are numbered. Yes, stage 4 cirrhosis. At that time, we call it end stage liver disease or end stage liver failure, ESLD or ESLF, end stage liver disease or end stage liver failure. The only thing that you can do at that time is liver transplant. Who is going to give you his or her liver? Tell me. Who? In Africa, we don't even, in Ghana here, we don't even do liver transplant. You have to go to Europe or South Africa. Now, unless you go and buy liver, yes, people pay, yes, there are some facilities that sell organs elsewhere. I actually don't know of any facility, but I know that there are some facilities that sell organs like kidneys. Somebody can wake up one day and go to a facility and tell them that, please remove my one kidney. I'm selling it. I'm selling it $2 million. I'm selling it this. Yes, they remove and then keep it. And then the moment they get a buyer, then they call you. They call you to come. That's it. And they pay you. I remember that one kidney remaining, it can fail. And if it fails, you are dead. That's it. Not good to sell your organs. So, okay. I think I have to, because when I decide to continue, I'll take too long. Liver cirrhosis is a long thing. So let me end at this stage. Charity, kindly write the page for me. Yes, kindly write the page for me. When we meet again, try and read about liver cirrhosis before we meet again. All right, so that you'll understand. These are some levels that I'll go through with you. Let me answer the questions some people have asked. So when we meet again, I'll start from the stages again. The stages. Okay, so sir, please, how do we go about those addictions? Sometimes they need rehab. They need rehab. Like send the person to the appropriate specialist. That's it. Rehabilitation. Okay. Send the person there. If it's alcohol that the person cannot stop, send the person to a rehab center. Yes, they have ways of managing those people. Yes, they have specialists around. They have ways of managing those people. It's not like they are going to stop them from the alcohol one day. No, they will follow what I said. Sometimes they can give them chemical that have the smell like alcohol. Yes, sometimes too they can add little alcohol to maybe a drink or something, and that also cause the body not to enter into alcohol withdrawal syndrome. There are other things like the cigarette. As for cigarette, they have a lot of items that have been designed like a cigarette. The smell appears like cigar, but when you smoke, it doesn't cause anything. So they start giving them that thing. They start giving them that thing, small, and then they will now be freed from the addiction gradually, and they are good to go. But if you tell the person himself that stop smoking, that person may not listen, because when he tries to go to toilet, it doesn't come. How do you expect the person to stop? So you have to send the person to the rehab. They have a lot of ways to go about these things. A lot of ways. And in about 2 months, 3 months, or even 1 month, the person is back. And the person is well. Even though some people can spend 1 year in rehab, some people spend more than that. Depending on the condition that sent the person there. So those are the best. Is there any question again? Is there any question? Charity, are you there? What was the reading assignment I gave you the last time?
Misplaced IUCD. Endometrial. So you told Loris to remind you.
Really? Oh, okay.
Yeah.
So Lawrence, what were the questions? Hey, are you there? Your mic is muted.
Sir, I'm there. Yeah, misplaced IUCD. And I'm coming home.
Oh, so all of you, nobody recalls the questions?
Degenerating fibroid.
Yeah.
And endometrial something metaplasia.
Endometrial osseous metaplasia. Okay.
Yeah,
So,
yes, sir.
So today time is fast spent. I'm not going to ask you, please. The next time we meet, I'll ask you. So I'll ask you individually, like randomly. So it's better if you haven't read, go and read, please. Okay. So we are likely to meet